just a little bit later. My name is Rhonda Williams, and I work for a pharmaceutical company by the name of Genentech, and I'm responsible for promoting and marketing and educating their HER2-positive products for breast cancer. So our company recruited Dr. Lauren McCullough to speak with Georgia Association of Physician Assistants tonight. I want to say good evening. Thank everyone for coming and tell you a little bit about Dr. Lauren E. McCullough. She is Associate Professor in the Department of Epidemiology at the Rollins School of Public Health. Her overarching research interests are in cancer epidemiology, specifically the contributions of obesity and the social environment to the tumor epigenome and the microenvironment, as well as disparities in cancer outcomes. Without further ado, we will begin playing our presentation.
Thank you so much for the in Atlanta and across our state. And so why Georgia? Georgia is really an ideal location to study racial disparities in breast cancer mortality for a number of reasons. First, there's substantial diversity by race and ethnicity. 32% of residents are Black, 9% Hispanic, and 4% non-Hispanic Asian. And by 2025, Georgia is projected to become the first majority minority state in the southeastern United States. Additionally, nearly 15% of the state lives in poverty. Similarly, 15% lack health insurance, which allows us to look at disparities by socioeconomics. Georgia boasts the largest Black middle class in the nation. We're actually tied for DC. And this is nice because it allows us to sort of think about class independent of race. And then finally, Georgia is among the top 5 states for the number of Blacks living in rural areas. And so all of this diversity really allows us to disentangle the effect from race, from class and geography, and explore intersections and intersectionality in context of thinking about breast cancer mortality disparities. Finally, a relatively recent statistic is Georgia is now only one of 6 states where breast cancer surpassed lung cancer as the leading cause of cancer mortality for non-Hispanic Black, but not non-Hispanic white women. And so this really tells the urgency of understanding differences by race, particularly in our state. So our preliminary work largely leveraged data from the Georgia Cancer Registry and focused on disparities in Metro Atlanta. And so I'm going to share results from those studies today. Just to put the disparity in context, non-Hispanic Black women compared to their non-Hispanic white women were twice as likely to die of breast cancer. And so that number is higher than the national average, which is about 40%. Black women are 40% more likely. And so disparities seem to be most pronounced in Atlanta and have been stable over the past decade or so. And so what we wanted to look at was the various drivers we think sort of contribute to these disparities, from tumor characteristics and treatment characteristics, thinking about quality of care. Is a woman receiving care according to guidelines? What types of facilities facilitate better or worse outcomes? And patient characteristics. And then finally, I'll get to our structural determinants and social determinants of health section. So to begin with tumor characteristics, just highlighting that compared to their white counterparts, Black women were more than twice as likely to die of breast cancer if they had an ER positive hormone receptor. And similarly, we found that Black women with luminal A disease were more than twice as likely to die compared to their white counterparts. The disparities were much less pronounced for women with ER negative disease or triple negative disease. The reason why this is so important is because first, I think there are some misconceptions out there. Most Black women actually get an ER positive disease, even though triple negative is more frequent among Black women compared to other race and ethnic groups. 60% of Black women are going to get ER positive disease. Second, we actually have effective treatment regimens for ER positive disease. Endocrine therapies work very well. And so this feels to be low hanging fruit. We have effective treatment regimens. Why is the disparity so robust? So within the context of ER positive disease, we thought perhaps there was some residual effects of genetics or treatment that we should consider. And so we decided to look at Oncotype DX score as a potential driver of these disparities. Oncotype DX is used to guide chemotherapy for women who are ER positive. And what we found was that testing and receipt of chemotherapy based on that Oncotype DX score was relatively comparable between race groups. The difference, though, was what we found and is shown here is that women with low Oncotype DX scores, Black women were more than twice as likely to die compared to their white counterparts. And so again, in sort of this, what we perceive as being a low risk group for poor prognosis, we're seeing more robust disparities. Next, we looked at receipt of guideline concordant care. So this was in accordance with NCCN guidelines. In Atlanta, actually, Black women were more likely to get initial care according to these guidelines, even though overall in our study population, guideline concordant care was quite low, so slightly less than 60%. What we found was that irrespective of whether or not a Black woman was guideline concordant or not, she was about twice as likely to die of breast cancer as her white counterpart. So for guideline concordant women, the hazard ratio was 2, and for non-guideline concordant women, the hazard ratio was 2. And so that looking at guideline concordance didn't really explain the disparities that we were seeing by race. We also looked at delays in surgery and found that Black women were twice as likely to have delays in surgery. And this was irrespective of the facility type. So, med school affiliated, for-profit, nonprofit, or quality metrics. So, was it a COC accredited hospital? And overall, if a woman experienced a delay, she was more likely to have a poor outcome from her breast cancer. And then finally, in terms of patient characteristics, we looked at a host of things. I'll highlight 2. One was that we found that women Black women who were privately insured were more than twice as likely to die compared to their white counterparts who are privately insured. We found about the same estimates for women who had Medicare. And so these women who we perceive as having higher access to care still were having outcomes that were far worse than their white counterparts. We found similar things looking at neighborhood SES just as a marker of economic status and economic advantage. We found that Black women that lived in high socioeconomic neighborhoods were still more than twice as likely to die compared to white women living in those same neighborhoods. You can see the effect among women living in low SES neighborhoods was much less robust. The hazard ratio was 1.29. And so these are important because typically we think in the context of disparities, you give women access, they have insurance, the disparities should narrow and should disappear. And we actually saw the opposite effect. Disparities were more robust. And I want to clarify here that when we're looking at disparities, we're looking within strata of these different variables. So within folks who are privately insured or who live in high socioeconomic neighborhoods. Of course, insurance and living in areas with better access overall improves outcomes. But within those groups, we still see robust disparities among Black women. And so these data have really just kind of made us think about, going from equality to equity, which I think largely was the push. You get people the supports they need. They should have similar outcomes as is depicted here in this middle cartoon. But what we've seen in guideline concordant care, insurance, and neighborhoods is not that they have equal outcomes. So really moving from equity to justice, understanding the root causes of the inequities and addressing those, I think is really sort of where at least our research group is going. And so in addition to Georgia having all of these features that make it well primed to think about breast cancer mortality disparities, Georgia is located in the Deep South with a long history of structural racism and discrimination. And so we are also well positioned to think about those factors as potential drivers of disparities in breast cancer. And so moving into social determinants of health, when we think about what are the drivers of disparities, often it's sort of bent into various areas across the continuum of care, cancer screening and diagnosis, site of care differences and treatment, and then, post-diagnosis and treatment, you're thinking about, long-term adherence and follow-up care. And so when you think about the contributing factors, in terms of cancer screening and stage of diagnosis, Black women typically present at, they have later stage disease and more aggressive cancer types. And that has been attributed to differences in health literacy, screening rates, although they are pretty equivalent in Georgia for an initial mammogram, as well as fear and medical mistrust. There are differences in site of care and treatment, and that has to do with differential access to top institutions, greater rates of delays, as I previously mentioned in our study, lower likelihood of receiving guideline concordant care, even though that's not the case in Atlanta, and then less access to new or more advanced treatments in clinical trials. And these are thought to be driven by, socioeconomic differences, access and logistical barriers such as transportation, as well as provider and patient concordance. And then in terms of treatment adherence and follow-up care, we see differences in response rates. We also see lower adherence among Black women and lower rates of participation in follow-up care and rehabilitation. And it is thought that that may be due to differential risk of comorbid conditions, again, fear and medical mistrust, as well as financial and logistical barriers and toxicities. And so when we think about, all of these differences in sort of the social determinants of health that are thought to underpin these differences, what is consistent among all of these is structural racism and discrimination. And so in thinking about the result that we found among, women who were privately insured or women who lived in higher SES neighborhoods, we just begin to think, is neighborhood socioeconomics and insurance really the right measure? It ignores generational wealth and access, and also it just ignores historical contexts of the lived environment and experience. Also, we've been thinking, do stressors, race-related stressors at upper economic levels, do they differ? And here are a few terms that are out in the literature. John Henryism, coined by Sherman James, formerly at Emory, just says that a strategy for coping with prolonged exposure to stress, such as discrimination, is resolved by expending high amounts of effort, which result in accumulating physiologic costs. So to overcome barriers and biases, Black women are expending greater effort at a cost, both mentally and physically. Shifting, relatively new term, is basically altering yourself for the expectations that people have of you. So I really like this example. Black women shift white as they head to work in the morning and shift Black as they head home each night. And you can imagine that shifting of your person can also result in physiologic consequences. And then finally, the minority tax, a term that most people are familiar with, and it's just the concept that when you're one of few racial and ethnic minorities, you're called upon more often than others because someone who looks like you needs to have a seat at the table. And so thinking through all these things in our preliminary data, we believe structural racism is a driver of access. It's a driver of neighborhood environment. It's a driver of comorbid conditions. And so we have begun to think about this structural piece by looking at redlining and lending bias. And so historic redlining exists in the Atlanta area, as many of you probably know. Historic redlining is a systematic denial of mortgage based on place. It was a part of the New Deal, and essentially Atlanta and several other cities these maps were created to guide mortgage lending for banks. And so there were areas that were literally sort of marked in red, as you can see here, that were areas where banks would not lend, and areas that were more favorable, the most favorable being here in green, where there was lending and an influx of economics. And so just to orient everyone, I've mapped Emory and the AU Center. You can see Emory is in this blue, more favorable area, whereas the AU Center, where Spelman, Morehouse, and Clark are in these redlined areas. As a native of Atlanta, I've just also mapped where my parents grew up, my mom in Collier Heights near the AU Center, and my dad in Joyland Park and in Carver Homes, both in redlined neighborhoods. And so, this redlining concept is really important because it not only guided real estate investment, but it also dictated, environmental exposures and availability of goods. And so, redlined areas have poor air quality. There's increased inter-urban heat. There's generally a lack of green space and known to have food deserts. And this map on the right really sort of represents this last point. The larger yellow circles represent supermarkets and grocery stores, whereas the smaller orange circles represent convenience stores. And qualitatively, you can look at this map and just notice the dearth of the large yellow circles or supermarkets and grocery stores in these redlined areas. And so this is a huge driver of access, of comorbid conditions like obesity and cardiovascular disease. And I spent a lot of time at my grandmother's house when I was young, and she always waited on the vegetable man to come. And for the life of me, I couldn't understand why don't we just go to the grocery store to get vegetables? And it is in part because there were no grocery stores within a 5-mile radius of our home. And so, we began to think about redlining in more contemporary ways. And working with Kristen Bayer at Medical College of Wisconsin, developed a contemporary redlining measure for Atlanta. Yes, redlining is illegal, but it continues in semi-section ways today. And you can see from this map, west of the city is an area still that has pronounced biases in mortgage lending. What we found was that women living in these areas had a 60% increase hazard of breast cancer mortality, even after adjusting for age and stage. Not surprisingly, 80% of non-Hispanic Black women lived in these areas compared to only 20% of non-Hispanic white women. Additionally, women residing in red line areas were more frequently diagnosed with triple negative breast cancer disease, 18% of Blacks versus 9% of whites, and were more frequently diagnosed with stage 4 disease. Lending bias, on the other hand, is a systematic denial of mortgage based on the applicant's race or ethnicity. So I go in to get a mortgage application. I am more likely to be denied that mortgage because I am a Black woman compared to my white counterpart. And so if you look at this map, the lending bias map is sort of the converse of the redlining map, where there's more pronounced lending bias in the northern and eastern parts of the city, less pronounced in the southwestern part of the city. And what we found was that if you lived in an area with pronounced lending bias, it was associated with 14% decrease in breast cancer mortality after adjusting for age and stage. Again, you know, people living in these areas, 60% were non-Hispanic white, only 26% were non-Hispanic Black. But what's interesting is that non-Hispanic Black women living in areas with pronounced lending bias experience no mortality reduction. And so there's something to say, not just about where you live currently, but about your history over time and how that can impact a prognostic outcome. And so our data are largely consistent with others who have recently published on redlining and cancer. Kirsten Bayer's paper recently came out, and it showed that as the redlining index increased, women often experience poor survival. And you can see the hazard ratios here in a very monotonic way. Redlining and survival goes down, or mortality goes up in this case. Nancy Krieger also looked at the role of redlining in cancer at multiple cancer sites in Massachusetts and found that risk of late stage diagnosis for breast and lung cancer was associated with living in a historically redlined area. And previously residing in those areas still had an impact on stage of diagnosis, even if the individual currently resided in an area of economic privilege. And so again, something about the historical nature of experiencing those environments gets embedded somehow to influence prognosis. And so working on these redlining projects really had us think more about place and health and the importance of understanding disparities across geographic areas. And so we began this mapping work to just better understand the landscape of disparities across our state. Obviously, rurality being an important sort of driver of cancer outcomes. We wanted to better contextualize the extent of disparities in the various counties. And so what you see here are race-specific standardized mortality ratios on the left, and race-specific breast cancer, 5-year breast cancer mortality rates on the right. Within each of those groups, you see two maps, one for non-Hispanic Blacks on the left and non-Hispanic whites on the right. And looking at these maps, you can see that in addition to there just being a dearth of data for non-Hispanic Blacks in certain counties, the maps typically are a little darker for non-Hispanic Black women, which I think is really sort of depicted in these race-specific 5-year breast cancer mortality rates. And so what we did with this was we went on to develop disparity maps using smoothing approaches to account for the heterogeneity across the state by race. And we were able to look at 3 sort of measures of disparity: the relative disparity, so Blacks compared to whites, the absolute disparity or the difference between those two groups, and then what we term in epidemiology the interaction contrast, which is by race, how does it compare to the state? So what you see here first is large consistency between these 3 measures, which is also always very good for a researcher to see, gives us a lot more confidence in our approach and in our data. But that Atlanta and Savannah stand out as being places with robust disparities, in addition to Putnam and Toombs County. And so, just thinking about these areas, we've already talked about the historic discrimination in housing that exists in Atlanta, and we know based on our redlining project still continues to this day. Savannah is also an area that has historic redlining. Here is the map here. A little difficult to see the color, but if you look closely, you can see the red and the blue and the yellow. We didn't know a lot about Toombs or Putnam County, but doing some digging, they are counties, obviously in Georgia, that have historic discrimination. And interestingly, to this day, still very tense race relations. So Putnam County recently voted against teaching critical race theory. And then, you know, HBO did this whole documentary on Toombs County because of their contemporary segregated proms and the fact that there was a young Black man killed in this county, and it was related to racial tensions. And so our take-home messages are that disparities by race are not simply a result of innate biology or access. There really are multiple drivers across the spectrum from sale to society, and that place-based structural factors really have to be considered in the landscape of breast cancer mortality disparities. And so when we think about our next steps for this work, one thing that we're really interested in is understanding how these structural factors get under the skin. Cancer is obviously a disease of the cells. And so understanding how the structural factors influence tumor promotion and progression, I think, is really important for conceiving interventions that are going to truly narrow these disparity gaps. And this is an active area of our research group. And so just by way of example, we have looked at neighborhood characteristics in relation to breast cancer methylation, which is an epigenomic shift in the tumor DNA of women. And we found that job density and college graduation were actually associated with methylation in a number of probes that are within genes that control inflammation and estrogen receptor activation. Similarly, we found that neighborhood redlining using our contemporary measure is associated with methylation in the breast tumor tissue. 36 different CPG sites were methylated, hypermethylated, as you can see here in this volcano plot. And the majority of sites were within genes that control inflammation, immune functioning, and oncogenic signaling. And so we are continuing to interrogate some of these sites, replicate these findings. Another next step is really to understand the role of comorbidities in treatment effectiveness in parents. Obesity is a huge one we think about just because of the disparities among Black women. Black women, 80% of Black women are overweight or obese at diagnosis compared to about 60% of white women. We know that obesity is, the disparity in obesity is not by happenstance. This institutionalized racism results in sorting of people into different neighborhoods, variable access to green space, grocery stores, environmental toxicants, as we discussed, which can lead to onset of obesity and a number of chronic conditions. Interestingly, when you look at the data, there are associations between residential racial segregation and obesity, but only among Black women. There are no associations among Black men, or white women, or Mexican men. And so this could be an important consideration for Black-white disparities in breast cancer. And again, as you can see, the disparities do exist and persist. And this is important because we know that obesity and related comorbid conditions can affect both treatment efficacy and tumor progression. So really understanding the links between obesity and outcomes and the mechanisms is really an important area. And then finally, engaging with local stakeholders to better understand geographic specific drivers of disparities and inform our future research to understand sort of the multi-level contributors to disparities in both recurrence and mortality is a third and important next step. We are working closely with all our community partners, trying to understand those maps and those pockets that have more pronounced or less pronounced disparities, and understanding the data behind it. So even areas that aren't necessarily desperate by race could be areas where everyone's just doing bad, and we want to know that too. And so by working with these various organizations and stakeholders within these regions, we hope that we can disseminate this information, but also get qualitative information back about what we should be looking at and incorporate that into our future research. So I would like to close by thanking our collaborators, our many trainees, which really drive this research forward, my staff, consumer advocate, and obviously the research funding that supports the work. Thank you very much.